I am in Spain, so this is fantastic. And thank you to Pindi and Osteo for getting all this ready for us. We have been doing a few webinars this year, and thanks to Mervyn, this one is free for everybody. So just to let you know, we're holding this conference on the 6th and 7th of April, just in a month's time. And Mervyn will be talking in that conference for all of us. Mervyn Waldman, next to Chris Campbell, Michelle Odon, and Sue Turner, exactly. And we will be hosting some workshops as well. So I think you have you want to see the information in the chat. You can see a chat box just underneath on the screen, and in that chat box you can write a few questions if you want to ask anything to Mervyn at the end of the webinar, and I will read them out to Mervyn. And then yeah, you have a link for the ticket tailor for the conference information. Also, to let you know, I don't know if everybody is aware of what the Institute is. The Institute is a charity association. We have been working for many, many years now, organizing courses in the UK mainly, but also we have many courses abroad, especially in Italy, Canada, and Spain, and now starting again in Germany, and also people connecting us from Australia. So we are kind of worldwide network, the Institute of Classical Osteopathy. Classical osteopathy is not something that it means to be old or is ankylosed, as some people said. We basically want to bring the old test alive, but also don't forget about the new research and new things that come up in osteopathy. And thanks to Mervyn, who works in a hospital, he's the most clear about this aspect. So in these courses that we run for the Institute, we run around 5 main things, which are body mechanics, principles, which is very important for us. We talk about physiology, applied anatomy, and last but not least, technique, but we call that practical application. So there is no technique without principles. That's what we always say. Anyway, I just wanted to introduce to all of you about the Institute and what we do. And I let you now with Mervyn and his conference. Thank you very much. I'll let you, Mervyn.
Thank you, Diego. Hello, everybody. I'm glad you're joining me for the next hour or so. Let me just give you a quick introduction as to my background. I've been in practice for over 45 years and in Israel for the past 30 years. And most of that time, I divided my week between hospital practice for half the week and the other half in private practice. And I entered hospital practice as soon as possible because I wanted to see as difficult a range of patients as possible, the kind of patients one very rarely sees in private practice, and to see whether osteopathic principles can be applied and can work in that setting, in that difficult setting, in the kind of background in which osteopathy was founded, because as you probably all remember or know, it wasn't just the simple back pain that they were seeing. They were dealing with epidemics. They were dealing with the most life and death-critical conditions imaginable, and often proving that there was a way to help these patients, these very sick patients, without the use of the heroic medications that were given over 100 years ago. In fact, osteopathy got off the ground historically because of its success in treating very dangerously ill patients during the great influenza epidemic at the end of the First World War. And as you probably know, hospitals opened very rapidly all over the United States, osteopathic hospitals, proving that you could produce very significant success without the use of dangerous medication. I hope the next hour will be stimulating and thought-provoking. I hope to share with you some of the experience I've gained over the years in hospital practice. And the subject of our webinar is a look at the cervical and brachial plexi, its treatment, but more important perhaps, the clinical assessment that's necessary to determine whether there's any compromise of the cervical and brachial plexi. Because if there's one thing that's been made all too clear from my own mistakes, it's that we tend to rush in far too quickly to treat, often knowing little or nothing of the pathology that's lying under our hands, and without having performed a truly professional medical examination. So if there's anything I can do in the next hour, it's to at least heighten our awareness and desire to find out more as to what might be happening just millimeters from our fingers, and thus prove to be safer and more skilled operators and physicians. One more point. Everything in the next hour or so in this video, in the PowerPoint, in the text of what I'm saying, will be available to everybody on YouTube. So I would ask you not to try to grasp all the details that I shall present you with. It's far too much. It's far too complex and sometimes quite deep. And it'll pass too quickly anyway. Recognize that you'll be able to spend all the time in the world that you may want at your own leisure when it comes onto YouTube. And so I suggest just enjoy the show for the next hour. Take in what you can, and perhaps if it's sufficiently interesting, go back over it slowly and surely in your own time. So let me kick off with a very strong statement. It's a reminder that there can be very few more vulnerable parts of the body to treat than the cervical spine. And there have probably been more patients lost to osteopathy by its mistreatment. Probably more so than any other part of the body. I personally have seen patients not return to some of the most experienced operators because of the bad reactions that followed mistreatment. What is the cause of such mistreatment? Well, I think it's very often the result of inadequate neurological and orthopedic assessment. The patient was not examined sufficiently to determine whether there's a potential underlying pathology. Unfortunately, and it's particularly worrying, is the fact that in the early stages of pathology of the neck, the signs and symptoms of compromise of the cervical and brachial plexi are often very subtle, and they do not present clinically in a very obvious way. And often, because they're not particularly specific in nature in these early stages, they can overlap with other more humdrum neurological conditions, such as somatic referred pain from the neck, or radicular pain, or even radiculopathy, and can therefore delay the diagnosis of a truly degenerative cervical myelopathy, for example. Let me just give you an example from some research that was published just 2 years ago as to how worrying this can be. In the results of this study of healthy individuals, I repeat, healthy individuals aged between 40 to 80, it showed that quite commonly cervical cord compression was detected on MRIs in up to 59% of that population. 59% of the population between 40 to 80, without having any significant symptoms, showed on MRIs cervical cord compression, spinal cord compression in the cervical area. 32% were in their 5th decade of life, showing cord compression, 67% in the 7th and 8th decades of life. But here's the really worrying figure. Of the 108 individuals with MRI signs of cervical compression, cord compression, only 2 out of the 108 reported related symptoms. It was silent, the cord compression, in the vast majority of cases. Of those who showed the cord compression on MRIs, 22% would go on to develop degenerative cervical myelopathy with significant symptoms over a 4-year period. Let me illustrate this problem with 2 current patients of mine. The first lives only 5 minutes car ride away in the next door village, and she's also a hospital colleague. And the other is a neighbor living only 5 minutes walk from where I live in my village. Let's take a look at the case histories of these 2 individuals. The first is a 43-year-old fit mother of 2 young teenagers, and she presented with mild neck discomfort and bilateral, relatively mild shooting pain into the hands on forward flexion of the head and the neck. She denied any associated trauma, no history of trauma whatsoever. The neurological examination was without any abnormal findings, not even carpal tunnel syndrome. The orthopedic and the osteopathic examinations were also uneventful, without my detecting any significant abnormality. As is often the case when presented with such symptoms, I suspected some compromise of the brachial plexus along its pathway from the cervical spine, through the thoracic inlet, or the shoulder, or the elbow, or the wrist, and started to treat on that presumption, hoping to detect some abnormal myofascial findings along the way and along the course of the brachial plexus. There was no response to 2 exploratory treatments, but she did report the onset of a mild sense of numbness in the thenar eminence and fingertips, all the fingertips, and it also began to appear in the other hand. The bilaterality of symptoms naturally worried me, and I referred the patient to a neurologist. An MRI of the cervical spine clearly revealed a 2T weighted white patch signal change in the cord at the level of C4. It indicated idiopathic cervical myelopathy. We'll look at a similar MRI scan a little later in this webinar. It was considered idiopathic because there were no signs on the MRI of any degenerative condition. No abnormal anatomical morphology, no functional abnormality on flexion and extension images that showed compression of the cervical cord, nothing that indicated what could cause ischemia that is thought necessary to cause myelopathy. The patient was left out to dry by the surgeon, as there wasn't anything to decompress by the surgeon or stabilize. He had nothing to do. The patient nevertheless asked me to continue to treat her in the hope that it may somehow prevent further deterioration and perhaps even enable an improvement. And naturally, she was a very worried woman. Having abandoned thrust to the neck, thrust to the spine for that matter, decades ago, and only using Littlejohn's classical articulatory procedures, I agreed to treating her and felt safe in doing so. It's now some 2 years down the line. She's only got the mildest reminder occasionally of dysesthesia in the hands, and a recent MRI shows a marked reduction in the size of the cord degeneration. Spontaneous remission, or the result of treatment, or a mixture of the two, I've no idea. In theory, accurate osteopathic treatment may have improved the supply of the vascular structures implicated in ischemia to the cord. On the other hand, the results of studies show that a subset of patients, a small minority of patients, are likely to stabilize clinically without surgery, and no doubt also without osteopathic intervention. The second case I want to bring to your attention, my close neighbor, is a 45-year-old mother of 4 young children. Healthy woman, presented with a chronic, pain that was continuous for at least 8 months across the upper thoracic spine and scapula. And it was of relatively recent origin. And then, more recently, she had difficulty writing with her right dominant hand. Now, these hand symptoms are frequently misdiagnosed as arising from compromise of the median nerve in the carpal tunnel. But I ruled it out very quickly when I used the Fallon's test and the Tinel sign. You remember what Fallon's test is, where you take the wrist and you press with your other hand deep into the wrist and you bend the hand over the wrist and over your thumb, and you hold the pressure for about half a minute to 3/4 of a minute. If you do not produce the symptoms of median nerve compression compromise, then there's no carpal tunnel likely to be present. Tinel sign, do you remember? You take the wrist and with your patella hammer, you gently tap over the carpal tunnel for about 15 seconds to 20 seconds. And again, if you do not produce the symptoms of paresthesia along the medial distribution, dermatome distribution, then again, it's very unlikely that you've got carpal tunnel syndrome. So that was certainly not the cause of her discomfort and pain and difficulty. Obviously, I carried out a full neurological examination, and I couldn't detect any deficit or loss of muscle strength or wasting. I did notice a significant loss of range of motion in the mid to lower cervical spine and began to treat appropriately. I began to suspect something more sinister when within a month she began to report fine finger use getting worse and the onset of occasional trembling in the right leg. I should have asked her if she had difficulty using her cell phone to type messages, as it's an early symptom of neurological disease, such as cervical myelopathy, or something worse. It's always worth asking for, by the way. Are they having difficulty with their cell phone, typing on the cell phone? Anyway, to cut a clinical history short, and luckily for me, following my insistence that she consult a neurologist for an opinion, within a month of my first seeing her, she was diagnosed on an MRI spinal scan as suffering from amyotrophic lateral sclerosis. Had I been able to repeat my neurological examination, I might have been already able to note brisker tendon reflex responses, perhaps Hoffman sign, which we'll look into a little later in this webinar, or the upgoing Babinski, or a positive bilateral exaggerated finger reflex jerk, which again I'll look at with you a little later, or perhaps the inability to perform the finger to the thumb tap test. Again, I'll demonstrate that on the video in a few moments. These are vitally important diagnostic tests, but they do not necessarily show up positively in the early stages. So what is important to remember is that a normal finding, because everything I had done had only produced normal findings, doesn't exclude disease. But if any of these tests do show up an abnormal finding, it is highly suggestive of disease. And therefore, it is very important to carry out these tests when conducting a neurological examination. Now, there's another very important point I want you to bear in mind. The extent of the compression of the spinal cord and the signal changes in the cord that are picked up on an MRI scan do not correlate well with the severity of symptoms. Even mild compression can account for severe disease. Now, tragically, this lady is rapidly deteriorating, and her life expectancy can be counted in months. Her death is likely to be miserable, usually through respiratory failure. If she's lucky, she'll die of pneumonia. I continue to attend her, try to visit her twice weekly on a home visit, try to cheer her up as best I can, but also to ease the accompanying musculoskeletal pains and disuse contractures. I'm technically, osteopathically, very challenged now, as she's hardly able to rise or move, and is too heavy for me to lift on my own to get her onto a treatment table. I have to do everything now with her sitting on a chair as best as possible. The important point I'm trying to make is that these two recent clinical cases that do turn up in practice are of cases that didn't turn up with an MRI in their hands. Therefore, we've got to treat cervical and brachial plexus signs and symptoms with a high level of suspicion of something that may be far beyond somatic dysfunction. For example, commonly related early stages of significant disease, neurological disease, can be neck stiffness, something as simple as neck stiffness, at times without pain. The symptoms can be unilateral. Most of us would get worried if it's bilateral, but they can often be unilateral and vary in severity, even on a daily basis. And there are even atypical symptoms, such as headaches and muscle cramps. And they can cause us to lower our examination standards and suspicions. Fortunately for us, most cases of something more serious than somatic dysfunction do present with early warning signs or symptoms, but only if we look for them diligently. I'll therefore spend much time in this webinar reminding ourselves of the importance of some key neurological and orthopedic tests that should always be carried out as routine on any patient presenting with cervical and brachial plexus symptoms. Perhaps, too, many of them will be new to you, or some of them will be long forgotten. So let's spend a few minutes, not more than 3 or 4 minutes, looking at a standard neurological examination that I was performing just last week on a patient, but with a few tips thrown in that I picked up in hospital and found invaluable. So let's have a go, and we'll look at the examination procedure, and then I'll go over it once again, stopping on the way to determine with you, to describe with you the significance of what it is I'm doing. So let's have a go. I should be asking you why, when it's a cervical or brachial plexus, I'm interested, for example, in testing the trigeminal nerve, sensory, and in a moment, motor as well, branches. Why would I be interested in the facial cranial nerve? Spinal accessory. Why would I be interested in the jaw reflex? Why am I testing whether there's pain in that arm as opposed to no pain in the shoulder when there may be cervical pathology? Why am I looking for absence of sensory perception in the supraclavicular nerve or in the axillary nerve? Again, why am I testing trapezius and looking for cervical pathology? Notice it takes just a few seconds to do these highly significant tests, which we'll be talking about shortly. All tests should be done bilaterally. I occasionally shorten things by only looking at one side. The patient you're looking at here suffered serious distress about a month ago with acute neck pain, inability to sleep because when lying down it was made that much worse, and median nerve dysesthesia, paresthesia in the thumb and first finger, and loss of power in the right hand. He, for the moment, has not had any CTs of his neck done, but should do. All the signs are of significant discopathy, of protrusion, if not prolapse, of C6 or C5, C5-6 disc, and the significant pressure on the nerve root producing the loss of motor power and loss of sensory expression. Watch carefully how minimal are his reflex responses, and in a moment watch how I ask him to tighten his jaw to exaggerate those minimum responses, and they do. This can be perfectly normal if it is bilateral, as it is in his case, minimum reflex responses. I'll talk about what I'm testing here, which is extremely important, and what sign I'm looking for there when I'm pressing down on his head. Now lifting him up from his head to ask for pain. A test you all know well, Romberg sign. I'm standing close by to make sure he doesn't fall if it is a positive response. And again, we'll look at why that may be very important when examining a patient with cervical or brachial plexus symptoms. So if it's not too much for you to let me go over that again, but a little more slowly, stopping on the way. This is called the finger jerk reflex. It is invaluable and very rarely done. Even my medical colleagues rarely know about this one. And it's been recently published in, I forget, but it'll come up. I can't remember. BMJ, I think, was the journal that recently published some results. No, it wasn't. It was another neurology. It was a neurology journal showing that if brisk responses, if the fingers respond more briskly than normal to the tap, that is, if they contract against the operator's fingers, more than just a mild contraction on both sides, it is a very strong indication that there is a cervical myelopathy present. It can also be done by tapping the biceps tendon reflex or the brachioradialis, and if they produce this finger flexion on the part of the patient, that too is an indicator of this reflex, abnormal reflex response, if it is exaggerated. In her case, there wasn't an exaggeration. Now, this next test is invaluable. It is so simple. It is one of the earliest signs of cervical myelopathy. If a patient cannot rapidly bring first finger to thumb, then you should begin to worry of significant spinal cord pathology. This was taught to me only 2 weeks ago at a lecture by an orthopedic surgeon to the faculty in my department. So this is quite new to me too, and I haven't ignored it since. It's been very valuable in my examinations since. Now I'm testing the sensory arm of the trigeminal nerve. And later in this webinar, I'm going to show you the close physiological and anatomical convergence of the upper cervical, C1, 2, and 3, with the trigeminal nucleus in the medulla, so that cervical pathology may only show up by way of abnormal trigeminal sensory or motor responses. You can't leave out testing the trigeminal nerve, or in this case, the facial. There are also links to the facial nerve with the upper cervical spine. Don't forget, this is still facial nerve. Now I'm testing the motor aspect of the trigeminal nerve. Chewing, mastication, is the motor arm of the trigeminal nerve in action. You test it by feeling the masseters under your fingers as the patient is asked to clench the jaw. Spinal accessory is intimately related with the first and second cervical nerves, so I was just testing to feel the sternocleidomastoid under my fingers as the patient presses his head against my hand, my resisting hand. The jaw reflex, one of the earliest signs of upper motor neuron disease, could be multiple sclerosis, it could be amyotrophic lateral sclerosis, is a hypersensitive response, a hyperreflex response to a gentle tap of the loose mandible. It's very simple, it takes a second or two to perform. Now, this again is a new paper that was only recently published in the past 2 years, showing statistically quite clearly that there is a way of almost certainly making sure that the pain felt in the arm or hand derives from the neck as opposed to compromise in the thoracic inlet or the shoulder or the elbow or the wrist for that matter. If on squeezing this middle to upper portion of the forearm, of the upper arm, there is pain, the cause of the pain, perhaps in the hand or the arm, is very likely to have arisen because of pathology in the cervical spine. If the pain arose because of compromise in the thoracic inlet, or the shoulder, or the carpal tunnel, there would not be pain on squeezing the arm. You must always test the other arm so that the patient can tell the difference. If he says, yes, this is much more painful on the arm affected by pain than on the other arm, then it is very likely that the pain is arising from the cervical spine. Very valuable test. Because often one isn't sure where the pain is arising from that is being expressed in the hand or the forearm or the elbow for that matter. And in his case, it was significantly more painful. Here, I'm comparing the pain in the arm with pain in and around the deltoid. It shouldn't be painful there compared to the upper arm where I was just squeezing a few seconds ago. And in his case, that is the case. It's only painful in the upper arm. We'll look at a little later as to why I'm interested in finding out whether there's any sensory loss in the supraclavicular and in the axillary branches of the brachial plexus. It may be one of the earliest indications of significant damage to the C4-5 nerve roots. Now, you all know I'm testing motor power here, but I'm doing so in a consistent way, in a systematic way. I want to know whether C5, C6, C7, and C8-T1 nerve roots are being affected by any compromise on those particular roots. So I began by testing. Let's go back a moment. I began by testing the C5 deltoid, C6 biceps. You didn't probably spot it, but I also tested his ability to extend the arm against me. That would be C7 triceps. And now C8-T1 in terms of the ability to open the fingers easily against pressure, against resistance, or to squeeze my hands equally strongly on both hands, and always look also for, I don't know whether I did it here, but I should have also shown the use of the thumb against resistance. Okay, let me go back to this for one second. No, I'll stop it here. This is the Hoffman's reflex. It is extremely important and often neglected. If it does prove positive, it means that the thumb is rapidly brought, approximated to the finger or the second finger when the middle finger is flicked. Let me go back a second and show it to you. It would indicate significant pathology of the spinal cord. It could be upper motor neuron, it could be lower motor neuron. It's usually upper motor neuron. So Hoffman's reflex, we'll look at it a little later to remind you of it. Again, don't ignore the more subtle sensory loss that may be only detected on gentle, soft touch with a cotton wool over the dermatomes of the brachial plexus innervation of the hand. Always check bilaterally to compare and contrast, to get the patient to compare and contrast. In his case, there was significant difference along the median nerve dermatome distribution of the right hand, as there was in motor power when he squeezed my hand. Fortunately for him, it is returning and he is recovering, and he certainly was able to sleep quite well after, I think, 4 treatments in close succession. I think 2 to 3 day gap in between. In the beginning, no, 2 day gaps in between. The tap is gentle. You should be able to provoke a response without slamming the patella happer. But now I needed him to reinforce the potential response by asking him to clench his jaws as tightly as possible. And only then did I get minor response. It was worrying until I went to the other side. And on the other side, similarly, there was a minimum reflex response in all the reflexes I tested. The biceps, the triceps, and the brachioradialis. Sometimes I also test the pronated teres. Now, looking for alar ligament instability. We're going to look at some PowerPoint slides of that. It's very rarely done. I don't know quite why, but certainly any patient of any age that suffered a serious throat infection, he hasn't, but I thought I'd show it to you anyway, should be tested for alar ligament instability of the atlas. It can, and I've seen 2 patients, 2 young patients who had this problem, and thank goodness they were already diagnosed with the problem when they came to me, because I certainly didn't know this test then, had turned up with alar ligament instability recent to their visit to me. Here I am turning the patient's head to one side. The transverse process of the axis should be moving in the other direction, if normal. So I'm grasping it. Now I'm performing Lermit's sign, strong pressure downwards on the head. If it were to produce a sharp electricity-like sensation in the legs, again, that is a very significant warning sign of significant neurological disease, a pathology. But again, it can be a very late sign. It may not come up at all positive in the early stages of the disease, of a disease. But it should be performed. Now I'm doing a distraction test. I want to know whether the neck pain he's suffering from may be as a result of myofascial strain. Whiplash very often produces considerable damage to myofascial and ligamentous structures. If there is any tear of ligamentous structures or muscular, and you perform this distraction test, lifting the patient's weight from his skull, my thumbs are under his nuchal line, the occipital nuchal line, it will be very painful as I perform this test. And therefore you are given a very good warning as to the kind of treatment you might want to provide and what you might want to avoid. So I perform this test on every patient with neck pain. I want to know whether it's mainly myofascial or muscular or ligamentous, as opposed to discopathy, in which case downward pressure will produce significant pain. And Rombergs. Rombergs shouldn't be avoided the moment there's any significant neurological symptoms or suspicion of neurological disease. But let me tell you one other finding that is clear on almost every piece of research I've ever read regarding something all of us see in elderly patients sooner or later, that is significant spinal stenosis of the lumbar spine. Believe it or not, in the presence of significant spinal stenosis, lumbar spinal stenosis, there will be a positive Romberg's sign in 90% of patients. In other words, 90% of patients with their eyes closed, asked to stand still with their legs together, will start to fall. You'll have to catch them if necessary. The stenosis so disrupts the proprioceptive impulses coming from the feet that it will produce a positive Romberg's sign. Right, we're now going to move on from the video to my PowerPoint, and I hope you found so far what I've been showing you of significant clinical interest. Let's see where I go to now. View share, PowerPoint coming up, and let's just get into full screen. And Diego, can I ask you whether everything is as it should be?
Yeah, everything is going fine. Thank you, Mervyn. Yes.
Right. Okay. Let's continue with the PowerPoint. This is a MRI of that picture of that patient I told you about in the next door village, the one who had the early mild symptoms of something neurological, but in fact was suffering a silent myelopathy. This is what it looked like. It's a T2 weighted MRI. How do you know it's T2? Because the CSF comes up very bright and white. Liquid fluid CSF comes up very clearly on a T2 weighted MRI, and as does any significant lesion of the spinal cord, comes up nice and bright and white. And look, in this particular case, it's not her MRI, but one that's very similar. There's a very mild protrusion, certainly not enough to cause the ischemia that should lead to something so pathological. We don't always know why, other than perhaps there being a morphological abnormality of the blood supply to that area of the spinal cord in this particular patient's case, which sooner or later will produce the ischemia that leads to the myelopathy. Next slide. As I said, the only presenting symptom was bilateral, relatively mild shooting pain into the hands on forward flexion of the head and neck. Something most of us would dismiss as being somatic dysfunction caused by somatic dysfunction. No Hoffman's or Lermit's sign was seen when I tried either test on them. Here's the flick of the Hoffman's test. You have a loose, relaxed wrist, and the operator flicks the second finger of the hand, and you watch for the thumb responding rapidly by approximating to the first finger. Hoffman's sign. Very important, particularly if it's bilateral, but it should also be significant if it's unilateral. It should also start worrying you if it's unilateral. There's the Lermit's sign, pressure down on the head and neck, causing this electric sensation to pass down to the legs. It's very clear, if it does happen, really do worry about multiple sclerosis or amyotrophic lateral sclerosis or cervical myelopathy. But again, it may only appear in a late stage, at a late stage of the disease. So let's begin looking a little more closely at the cervical plexus. And I just want to spend a moment to remind you of something that is rather odd, and that is that C1 is entirely a motor nerve. It has no sensory fibers whatsoever. It supplies the back of the head, and possibly because the back of the head and neck are exposed to cold and wind more than other parts of the body, evolutionary-wise, we have developed better to avoid having sensory fibers in that very exposed area. And so C1 is entirely devoted to a motor innovation. The supraclavicular nerve, which we looked at earlier, is a nerve that is affected by the C3 fibers as well as C4, so it could be one of the only early signs of a degenerative condition of significance at C3 and possibly more so at C4. Now, this is something that isn't sufficiently talked about, but it's certainly the cause of a great deal of research in the past 10 years regarding every type of headache imaginable, including migraines of the worst kind and cluster headaches. And that is the fact that C1, C2, and C3 converge with the trigeminal nerve in the trigemino-cervical nucleus in the medulla, which means that you can get a complex range of symptoms appearing in the trigeminal distribution, sensory and motor, sensory or motor, because of cervical, upper cervical dysfunction or pathology. And there, a slide that makes it a little clearer. So we must quickly test the motor and sensory branches of the trigeminal nerve if we're interested in knowing whether there is significant upper cervical pathology. I showed this slide 10 days ago to a neurologist who I respect greatly. She's a close colleague of mine in the department. And we were talking about one or two things, and she happened to spot this slide, and she went overboard with interest and immediately wanted me to send her a copy of it to her email address for her use in her own lectures. She had never seen something so clearly describing the remarkable interconnection between the first and second cervicals, not just with the vagus, but also with the superior cervical ganglion and the cranial nerves, both 11 and 12, and the 9th cranial nerve. The interconnection is so beautifully illustrated in this classical SIBA description. Interestingly, in later editions of SIBA's neurology texts, it disappeared. But I was lucky to have an early edition, and have used this particular slide very frequently. I won't go into more detail. I could just talk about this particular slide for half a video, I think, in terms of its clinical significance. Not least, notice the meningeal branch of the vagus, the small branch which supplies the vagus and is full of nociceptors, and probably is a major part of any pain felt in a whole range of headaches. Let me look a little more closely with you at this sympathetic cervical connection. If you can see it on your bigger screens, I hope you're using bigger screens than my tiny laptop, you'll see this beautiful connection through the gray rami as the sympathetic nerves pass up the sympathetic chain into the neck from the upper cervical origins of the sympathetic gray cells, and they only emerge with the cervical nerves via these gray rami, and that is where they are vulnerable to compromise. The early osteopaths always thought that these nerves, these gray rami, and the white rami lower down from T2 to L2, were very, very easily compromised by myofascial tensions in the muscles surrounding them and through which they pass to reach the cervical nerves, which in turn are very often compromised within the foramina. But these gray rami and white rami lower down were thought to be particularly vulnerable, which means that when we treat symptoms that may have connection with the sympathetic or parasympathetic nervous system, it can involve symptoms like sweating or vertigo. Then we must also be ready with our fingers to check and treat, if necessary, the anterior throat. And it's beautiful work, it's delicate work, but it can make all the difference. But it's very often forgotten in osteopathic treatment. But it means we've forgotten our anatomy and our applied anatomy. Just a quick reminder. When we're looking at the base of the skull, we're looking mainly at where our fingers may most make an impression on the insertions close to and around the orifices that are ones we can most easily reach. And they are the jugular foramen and the hypoglossal canal, through which pass 9th, 10th, 11th, and 12th cranial nerves, some of the most significant nerves of the body. And we can get our fingers very close to the major muscles that insert along the nuchal line and would possibly compromise these particular cranial nerves. We get in there quietly and we try to release any points of resistance. That phrase comes up time again in Littlejohn's analysis of what we're trying to do with our fingers. Anywhere in the body, we're looking for compromise which will be expressed anatomically and physiologically by way of points of resistance. Resistance to movement or resistance to our fingers attempting to stretch or move the soft tissues under our hands. So we test with a cotton wool bud and with a pinprick for the two major pathways, sensation pathways, that of pain along the along the spinal thalamic columns, and soft touch along the dorsal columns, including vibration sense if you want, along and around the whole of the skull to C1, C2, and 3, the back of the skull and neck, and of course the trigeminal nerve to the anterior aspect of the face, and the anterior throat to C2 and 3. Now look, I said that one of the important tests is to test for alar ligament weakening, and you do that by holding on to the TP, the SP of C2, which is very prominent. You can't reach the SP of the atlas, it's too deep. When you turn the head, C2 should be moving in the opposite direction, or give you that sense of moving in the opposite direction. But here's an example of the kind of thing that will happen if the alar ligament is over-relaxed. There'll be a subluxation at the facet joint of C1 on C2, and that is potentially dangerous. God help you if you use any high velocity or over-strong articulatory techniques. There should be no need to use those techniques if you follow Littlejohn's teachings. None at all. Every day in hospital practice, I treat the most difficult cases imaginable and have never needed to use high velocity thrusts of any kind, anywhere in the spine. And there it is, a gentle movement of the skull in one direction, holding the SP of the axis in the other, between index and thumb. Rotate the head to one side, the SP should seem to rotate to the other if the alar ligament is intact. It's particularly important, I haven't mentioned it yet, if patients are on steroids, and lots of patients are on steroids, or if they've got rheumatoid arthritis, or neck pain following a serious throat infection, because the alar ligament is sometimes very prone to weakening as a result of steroids or rheumatoid arthritis or infection, throat infection. The upper neck includes the arterial blood supply. The vertebral artery, as you probably remember, is particularly prone to anomalies that you will never know about because you're not going to do a Doppler. But you must presume that it is present because you only have to make a mistake once, and you can potentially kill the patient. And the anomaly is inevitably at this 90-degree junction, possibly on one side only, at the C1, C2 level. And there's a clearer illustration, I hope it's clearer on your screens than it is on mine, of the potential for vertebrobasilar compromise. And here's an even better illustration of this acute angle the vertebral artery has to pass through when it goes through the atlas to enter the skull. Now, this is a test I use on anybody that presents with any degree of vertigo. It's so simple, it's done very gently, but it can also indicate serious upper neuron disease, cortical disease, or cerebellar disease. How do you know whether it is merely an inner ear condition producing vertigo, or potentially an upper cervical dysfunction that is producing the vertigo, as opposed to a central brain lesion? Well, as you bring the head of the patient gently backwards and side bend and rotate to the same side, you look at the eyes for nystagmus. If the nystagmus stops after 30 seconds to a minute, as it should do, then there's nothing to worry about in terms of a central lesion. If it continues the nystagmus beyond that period of time and doesn't stop, start to worry and send them off immediately to a consultant or to the hospital, because it may very likely be a central lesion affecting the brainstem or the cerebellum. So you look for nystagmus. If there's any facial numbness, send them straight off to the hospital. If there's any change in their voice pattern, send them off to the hospital. If they begin to sweat excessively as a sympathetic response, send them off to the hospital. It's such an easy test to perform. Why neglect it? And here's a simple MRI. Again, the only symptom in this particular case was of vertigo. And only when the MRI was done was it obvious as to why. There was significant spinal cord compression. And now here are 3 MRIs of the same patient who again had no obvious instability. In A, yes, there's There's discopathy, there's protrusion, there is definite narrowing of the spinal cord, which would be worrying. But in neutral, that is forward bending, it seems without significant pressure or degenerative possibilities. But only when the MRI was taken in full backward bending was it obvious that there was multi-level degenerative central canal stenosis, significant narrowing, and cord compression. Now, it's very rare that MRIs are ever taken as dynamic MRIs, both extreme forward bending and extreme backward bending, which means we have to presume the worst very often, because we're not going to get MRIs that show forward bending and backward bending. And again, a vertigo that couldn't be explained until a simple X-ray was done, showing an anterolisthesis of C3 on C4. That was the only sign that showed up that could explain the vertigo. Behind many of these degenerative changes is not necessarily something genetic, but something that arises as a result of chronic misuse of the neck. And this is possibly one of the most typical examples, the forward head posture. Increasingly looked at are the possible effects on the sympathetic chain as a result of these degenerative conditions. The sort of symptoms we've already been looking at, where there is a degree of impingement of the cervical sympathetic cord. Here you see an anterolisthesis and the possible effects on the cord. There's been capsular ligament injury causing the instability. So when a patient has obvious postural misuse, be wary that there could be significant degenerative changes in the cervical spine. This one slide, which hopefully you'll look at in your own time, sums up all the kind of degenerative conditions that can lead to spinal cord compression. Most of it you already know in terms of ligamentum flavum thickening, in terms of disc protrusions. There is one thing that is missing on this particular slide. They haven't included facet hypertrophy, facet degenerative changes with hypertrophy, because that often does include significant pressure on the spinal cord. But this is the everyday today degenerative changes that can already begin in the early 40s, in the life of a male or female in their 40s. And a case report is worth reading of a 70-year-old woman who presented in a pain management clinic with complaints of lower back pain and bilateral calf pain with a certain degree of weakness in the legs. And the clinical impression that the physicians examining her had was of perhaps lumbar radiculopathy. Only when they did an MRI were disc bulges revealed, which could not nevertheless explain the weakness of her legs or the numbness, which prompted the physicians for further imaging of the neck. And only when they imaged the neck did they see the cervical myelopathy. So the myelopathy in the neck was, without neck pain, was silent, but the symptoms were already present in the lower limbs. Just a clinical hint, a clinical suggestion is that if any patient has difficulty rising from the chair because of weakness of the flexor muscles of the legs, start thinking of cervical spinal cord degenerative disease. It's a very useful early sign that something is happening of great significance in the cervical spinal cord. Difficulty getting out of the chair because of weakness of the leg flexors. And again, another simple MRI, T-weighted. T2 weighted is the best one, T2 weighted as opposed to T1. It shows up much more clearly. And it was silent. There were no symptoms. It was by chance that the patient had an MRI of the neck done. These three slides you can look at in your own time, but it's a reminder that possibly behind some of the most significant degenerative conditions of the cervical spine lie the changes that are affected in the arterial blood supply to the spinal cord itself, to the grey cells themselves. They are very delicate. They are lacking in valves to a great extent. They are very slender indeed. And one fact that is often neglected in research is the possible effect on the even more delicate, even more prone to compromise lymphatic system, venous system. The veins are even more delicate and could possibly affect, through back pressure, the parallel arterial supply. It's something that hasn't been looked at significantly. Just one paper recently I noticed was looking at the possible effects on the blood supply to the spinal cord as a result of back pressure buildups in the venous system. And the venous system is the side that is most affected by myofascial compromise. Just quickly looking at headaches, it's so common in osteopathic practice to have patients come with various problems affecting head pain or causing head pain. And if we look at it in terms of recent research, possibly one of the finest authors to look at in terms of the connection between pain and musculoskeletal sources is Bok-Duk. I never know how to pronounce his name properly, but he points out that cervicogenic headache can arise through a number of cervical factors and extracervical factors. The upper cervical synovial joints, the upper cervical muscles, the C2 to C3 disc often turns up as a cause of headache. But notice also the vertebral and internal carotid arteries are thought to be significant causes of cervicogenic headache. How can these arteries cause pain? Well, as you probably all know, the muscular coats are heavily supplied with nociceptors. And finally, a very significant cause of major headaches is the highly sensitive dura mater of the upper spinal cord and of the posterior cranial fossa. The dura mater are supplied with nociceptors from C1, C2, vagus, and the sympathetic supply. Everything that supplies the dura mater is supplied with contains masses of nociceptors. So it is possibly the most painful part of the head in terms of any degree of stress to it. And experiments in normal volunteers have easily established that the cervical muscles and joints are also major sources of headache. And we look often very deep to these muscles, deep to the occipito-atlantal axial articulations for some of the most significant cervical expressions of head pain and headaches. Don't forget the fascial links going up from the rest of the spine and body for that matter into the occipitalis muscle. Sorry, my cursor's disappeared. Occipitalis and the gallia aponeurotica muscle right into the frontalis muscle. You treat these muscles manually in osteopathic classical technique as readily as you treat the neck. It's included in the relaxation But I should first say, in the search for any significant points of resistance, so as to know where to concentrate your attempts at releasing that resistance. These are very significant muscles. The rectus capitis has been shown to have bridges. Bridges denoted at the occipito-atlantal junction between the rectus capitis posterior minor and the posterior spinal dura. Again, my neurologist colleague went bananas on these two slides. She said, this is where all the research is going on today in terms of the worst kind of migraines and cluster headaches. The relationship between the upper cervical spine and the posterior spinal dura. And here it is. This was discovered already 20 years ago, from a research paper published over 20 years ago, between the posterior rectus capitis minor muscle and the spinal dura. The ligamentum nuchae have also been found to be continuous with the posterior cervical spinal dura. And we can treat the ligamentum nuchae with our fingers if we know how to get in there without hurting the patient. I hate this particular test. It should never be done. It's unsafe. It can produce significant reaction on the patient. And to cap it all, when they recently did some research as to its sensitivity and specificity, both sensitivity and specificity were very low indeed. So forget about it. Don't do it. It's dangerous and it's not accurate. Let's quickly move on to the brachial plexus. Diego, are you all still there with me, or have you all fallen asleep or bored out of your minds?
No, we are all here listening. Yes, people are asking some questions and they are saying how good it is. So
if I give another 10 minutes, will you all stay with me?
Yeah, well, it's fine. Yeah, with me.
Okay.
Yeah.
Okay.
Is people happy with 10 minutes? Yeah.
Okay. So here's a reminder of two tests that you saw me performing with cotton wool and a pinprick, looking for the supraclavicular nerve and for the axillary nerve, both of which may be the only indication of upper and lower brachial plexus pathology. Test for any loss of sensory response in these two areas. We're looking for impingement syndromes. We don't call it impingement. It sounds much better when you talk to medical colleagues or you write up a medical report to call it neuro or microvascular compromise. But when I talk to medical colleagues about osteopathy, and I have to do it every week because I get medical students coming in their fifth or sixth years on rotation in different departments in the hospital, I have to say to them as quickly as possible something that explains osteopathic examination procedures as clearly as possible in medical terms that they will understand and approve of. So I use these examples very early on in my discussion. I remind them of the carpal tunnel syndrome. I remind them of the brachial plexus syndrome. I remind them of the piriformis syndrome, and I remind them of neuralgia parasitica. They know all these syndromes as being as a result of impingement of the underlying nerves because of myofascial structures, whether it's the carpal roof, whether it's the piriformis on the sciatic nerve, whether it's the cutaneous nerve as a result of the underlying inguinal ligament, and whether it's brachial plexus as it passes through between the first and second ribs and the clavicle. They know these to be impingement syndromes, and I say I'm looking for similar syndromes anywhere in the body, particularly along the spinal column, but it can be the shoulder, it can be the wrist, it can be the elbow, it can be the abdomen. And then I can go into more detail with most of them still listening to me with a degree of interest. I haven't lost them yet. So here you can see the potential for compromise, for impingement of the suprascapular nerve and artery. Here you can see the potential for compromise beneath the teres minor of the axillary nerve. Again, looking at these two forgotten nerves, which are so simple to test and which are prone to compromise as they pass through the myofascial structures of the neck and shoulder and upper shoulder area. You've got to look more carefully when there are radicular signs. It's well worth passing across all the dermatomes with your soft cotton wool or your pinprick for pain. Otherwise, you'll miss potentially the dermatome that's affected. Don't ignore it. It's so quick and easy to do. And the patient thinks you are very professional when you're doing these examinations prior to any osteopathic treatment, and repeating them perhaps at subsequent visits when you have any suspicion that things aren't going well enough. The thoracic inlet. I heard a lecture just on the thoracic inlet about 2 months ago. There's so much one can talk about in terms of the potential for neuro and microvascular compromise. We treat this area. We raise the first rib. We lower the first rib. We raise the second. We lower the second. We raise the clavicle and release the infraclavicular musculature that is often pulling it down, into the thoracic inlet. We do so using arm leverages usually, and I'll be showing you that kind of thing on film at the conference in April. And those of you lucky enough to have places in the workshops, it'll be a very important part of the practical demonstrations. But it will be shown on film as well at the conference at my lecture. As will other parts of the cervical and cervical spine in terms of classical Littlejohn, non-invasive, non-dangerous diagnostic and treatment maneuvers. Again, there are vascular structures that are potentially compromised, not just neurological. Of the vascular, the vein is the most fragile, and that is often where the first signs of distress will be felt in the vascular venous side. And what is not shown here, of course, is the lymphatics that also are very significant in the thoracic inlet. I just wanted to remind you that a nerve that is often forgotten but does become compromised, sorry, I'll show it to you again, is the long thoracic nerve. I saw a case in hospital just last night. I was asked to come in and give my opinion, a biomedical colleague of a patient who was suffering considerable pain in and around the lower inner half of the scapula. It's deep under the scapula, and I thought perhaps the long thoracic nerve is involved. It sounded so much like the supply of the long thoracic nerve, so I asked him to do a simple test that you should all know. Wait, I'll just remind you of what it looks like anatomically and how it can be compromised. That's part of the long thoracic artery. I've lost the nerve. There it is. There's the long thoracic nerve. So I asked him to do a simple test that you all know, to press up against a wall, and there was a hint of ringing of one of the scapula, a hint. So that wasn't enough to prove anything, but I then asked the patient to slowly raise his lower arms out to the side and above his head. And if you watch the movement of the scapula, you could quite clearly see that there wasn't the nice, smooth scapular rhythm across the ribs that should be present if the serratus anterior is functioning normally. Something was affecting the serratus anterior muscle, and that can only be the long thoracic nerve, and so somewhere along its passageway there's compromise. My job now is to look for where that may be and whether it can be revived, whether it can be released. We search anywhere along the pathway for compromise. It can be, again, thoracic inlet. It can be within the shoulder itself. It's not uncommon along the ulnar nerve or the radial passageway, depending on the ulnar or radial nerve being compromised. It can be along the shaft of the arm, where the musculature, perhaps from overuse, repetitive strain, can produce symptoms affecting the medial ulnar or radial nerve along the pathway through the forearm, and of course the well-known carpal tunnel. Finally, if you're not totally bored or fast asleep, may I remind you of the importance of Tinel's sign. It's one of the simplest things we can do whenever we're unsure where compromise might be. Tap the area where there may be compromise by myofascial structures. If it elicits the symptoms, in this case the ulnar nerve, tapping the elbow, will tell you immediately that there's a very high chance that that's exactly where the compromise is coming from. So let's not forget Tinel's sign. One or two last slides. I would never dream of treating the neck without looking at the rest of the body and possibly treating the rest of the body. There are times I cannot touch the neck because it is too painful or too dangerous, but will reduce the tension in the neck as I reduce the tension all the way along the myofascial continuity from the feet and lower limbs across the pelvic girdle and up the lumbar and thoracic spine into the leg. This is possibly one of the most beautiful dissections I've ever seen regarding that myofascial continuity. And so many times in the first few days or weeks of treating the acute neck, I can hardly touch the neck because of either the pain or the instability. But you can produce significant relief from below up if you know your body mechanics. That brings me to the end of my talk, and I'll be very happy to accept any questions from anyone that's still awake.
Thank you very much, Mervyn. That was an amazing talk, and it went by very quick, very fast. You made it so interesting, and it's so you know, everything that we need to know on a daily basis in our osteopathic practice. There are a few questions. I think Pindy can read them out for you.
Very good.
No worries. Thank you, Mervyn. Mahmoud would like to ask, at the beginning of your lecture, why pain from cervical provoked by compression of upper arm? What is it in relation? Sorry, I read it out word for word.
Yes.
That was the question.
Okay.
Why is pain provoked in the upper arm from provoking the cervical with compression?
Okay. The compression on the top of the head will produce pain in the arm if there's significant discopathy, for example, a significant protrusion or prolapse from C4 down to C8 nerve roots. The dermatome expression of pain can only arise if there is direct pressure of nerve roots, either as they exit from the spinal cord within the foramina or as they leave the foramina. So that test is simply exaggerating a potential source of pressure upon nerve roots.
Thank
I
you.
hope that answered it.
Sorry, Ahmed, I didn't really understand. Thank you, Mervyn. Ahmed had another question, but I didn't quite understand it. Ahmed, do you mind just clarifying your question? It was about cervical vertigo and the relationship between cervical compromise and vertigo. If Ahmed would likely kindly elaborate on what you mean by that question, please.
Okay. I firstly wanted to show you how vertigo may often arise through something we never expect, which is a condition like cervical myelopathy. But the spinal cord degeneration can produce vertigo. More often than not, vertigo results from the loosening of the otolithic crystals within the inner ear. In other words, it's benign paroxysmal vertigo, And until the crystals resettle in the inner ear, the patient suffers significant vertigo. I've suffered it twice in my life. When turning over in bed on waking in the morning, the whole room is spinning, and for 2 or 3 days, it was murder. I could hardly move out of bed without collapsing because of it. Another source of vertigo, which is not often admitted by physicians, is when the upper cervical spine is irritated. There is some dysfunction in the mechanics of the upper cervical spine, and there is obviously some neurological relationship between the upper cervical spine and the auditory nerve, which includes its supply to the vestibular mechanism in the inner ear. I haven't worked out the anatomy, but it is well known that facet degenerative conditions in the upper neck, whether it's C2-3 or C3-4, can often result in vertigo in patients with that condition. I hope that answered the question.
Sorry, I muted myself again. It did. Thank you, Mervyn. Bob would like to know, or Bob is curious to know, what percentage of your patients have cervical and brachial issues as covered in this webinar?
You mean how many of them have significant cervical pathology, such as myelopathy, or even more problematic diseases such as MS or ALS? Is that the question?
It just says, I'm curious to know what percentage of Mervyn's patients have cervical and brachial issues as covered in the webinar.
Well, a great many have cervical and brachial plexus signs and symptoms of disturbance and disease. Of those that show signs and symptoms of radiculopathy, for example, or loss of motor power, I would say 1 in 50 have perhaps a significant neurological disease. It's rare, but it will turn up if you look for it.
Thank you. And another question here from Ahmed is it true that the long thoracic nerve is compromised in thoracic outlet syndrome?
It is, as far as I know, that is one of the areas it can be compromised. It's more likely to be compromised as it begins to pass down to and in front of the scapula. So we test for that scapular rhythm very frequently when we raise the arm and perform a number of movements with the arm and the other hand placed along the vertebral border of the scapula. We're looking for any undue resistance to the gentle movements we're inducing with the arm as the lever.
Thank you very much, Mervyn. So would anybody else like to ask Mervyn a question? It's a great opportunity, and we're taking the questions for a few minutes, and then we'll wrap up.
I think there was a question sent in by email. I don't have it in front of me. And it was, if I remember, to explain a little more as to the thinking behind Littlejohn's typical push and pull maneuvers. Forgive me if I don't answer that question tonight. It will come up in the talk I shall be giving at the conference with demonstrations, and it will come up very significantly in the workshops. But I would need more time, and I think I'm stretching your patience quite a bit, given how long we've been at it so far this evening. So, if you'll forgive me, I think that's probably the maximum any of us can take this evening. But please do remember You've got all the time in the world to go over everything I've said and shown you when it comes up on YouTube quite shortly.
Yes, agree, Mervyn. Thank you very much. Yeah, it was a fantastic evening, and I think all the messages are, so thankful for this wonderful lecture and this kind of tutorial with all the nerves. Just to remind everybody, Mervyn will be in London next 7th of April in the conference that we are holding in London at Core Clapton. So hopefully I will see you all there, and I think we can now say goodbye. You can log into the website of the Institute for more information about courses and more webinars, also in the social media, Facebook, and soon I hopefully will be available this webinar in the YouTube channel of the ICO. So yeah, I'll catch you soon, everybody. Thank you for being here. We had about 80 people logging at one point, 85 people. So thanks, Mervyn, and Pete, and Osteo. Yeah.
And see you soon.
See you soon. Bye-bye. Cheers.
Thank you, Mervyn. Thank you, everyone, for logging in. Happy to have you. Do check out the details on our Facebook page. We will announce when this will be available on YouTube via the Facebook page. We'll also send you out an email post webinar so we can share conference details. Diego pointed out that we are running a flash offer right now with the links in the chat box. We'd love to have you at the conference and the workshops available. It's a real experience to hear some international speakers, including Mervyn, and really interact with the speakers. There's such high quality lectures that you won't get to see people like that anywhere else. So please join us. There's a link in the chat box, and you'll save 10% off of that today. Thank you so much, both of you. You still stuck around to hear me talk. Yes, so it'll be wonderful to have you. Now, this year we're hosting in London at Core Clapton. And if you know Core Clapton, it's Danny Orchard's establishment. It's a wonderful establishment. The ICO hosted there a couple of weeks ago, and it was brilliant. Everyone really enjoyed it. So it'd be great to have you all there and to check it out. So click on the link, follow that link, and save 10% today. That offer won't be available after we finish this webinar. So click on it now and check it out. And that's it from me.
Yeah, no, brilliant. Thank you very much for reminding us. And I see you soon, everybody.
Bye.
Take care. Good night.
Bye.
Good night.
Good night, everybody, and thank you all. Bye.